Hello everybody, this is Dr. Nadeem. We are with Neelam Path Lectures, the Pursue series. As you are aware, all our lectures are available on YouTube. We have a Telegram group for accessing all lecture related information. You can join the group. We have a Google Drive where the PDF of all lectures are available. These are the disclaimers, and we are with phase 3, which is recorded pathology lectures. And we are alongside, we are doing our dermatopathology lectures, which is Pursue 26. And today we have Pursue 26C, which is terms and definition in dermatopathology. And we are streaming from AIIMS, Jodhpur. To speak on this topic, we have Dr. Divya Aggarwal. She is an MD, DNB, PDCC, Neuropathology. Presently, she's an assistant professor in pathology at AIIMS, Jodhpur. She has got more than 65 publications in national and international journals, and also one book chapter. She is a recipient of the Nalini Bal Thakkar Award in 2016, AOGIN Best Paper Award in 2016, AOGIN Singapore Travel Grant in 2016, Kusum Pandit Memorial Award in 2017, President NBE Gold Medal in 2018, ASD and DSI Best Paper Award in 2019, APDW Travel Grant in 2019, the famous Dr. Panna Monisha Chaudhary Memorial Award in 2022. So Dr. Divya Aggarwal will be speaking on a very basic topic, which is terms and definition in dermatopathology, which is very essential to understand the topics of dermatopathology as we go ahead. So over to Dr. Divya Aggarwal. Ma'am, please start your lecture. Thank you.
Hello everyone. Today we will be discussing the terms and definitions in dermatopathology. So most of the descriptions in dermatopathology use specific terms which can describe any of the changes which are occurring in the epidermis, dermis or the subcutis. When you actually start reading the terms, you realize that most of the terms are actually pertaining to what's going on in the epidermis. There are a few terms which describe some features which you see in the dermis, and there are again a very few terms limited to the subcutis. So we start with the largest chunk of terms which describe the changes in epidermis. So you already know the layers of the epidermis, which has the stratum corneum, the granular layer where you see the keratohyaline granules, the largest, thickest kind of layer which is the stratum spinosum, and the basal layer which has these pigmented cells. So the first term that we're going to discuss is hyperkeratosis. Hyperkeratosis is increase in the thickness of the stratum corneum. So you have the stratum corneum, but remember that to call a skin biopsy as having hyperkeratosis, you first need to know the site of that skin biopsy. There are certain areas in the body where the skin already has a thick corneum layer, with palms and soles, that is your acral skin, being the most common of them. So if you're talking about acral skin, you use the term hyperkeratosis only when you have in your mind a reference of what the usual acral skin looks like, and then you would label it as hyperkeratotic. So to sum up, hyperkeratosis is just a thickening or an increase in the thickness of the stratum corneum compared to what is normal for that area of biopsy. Now, hyperkeratosis can further be divided into orthokeratosis and parakeratosis. Ortho basically means that it's happening in the way that it's supposed to happen, but it is just thickened. So normally when you look at the corneum layer, there should be no remnant nuclei in the stratum corneum. So your keratinocytes lose their nuclei and they come and sit in the stratum corneum. And if there are no nuclei, then you're looking at orthokeratosis, which is again known as orthokeratotic hyperkeratosis. Now this orthokeratotic hyperkeratosis can further be of two types. Either it has this basket weave appearance where there is some space to breathe and it kind of looks like a nice weave of these keratin cells, which you call as basket weave orthokeratosis, or you can have compact orthokeratosis, which is basically a thick orthokeratotic scale with no space, breathing space in between. The second term is parakeratotic hyperkeratosis, which is basically when your stratum corneum decides to retain its nuclei. Usually you see that when the turnover in the skin is increased, and these nuclei will be sitting in the corneum layer, which is what we call as parakeratosis or parakeratotic hyperkeratosis. The next term is a crust or a scale crust, which is actually a combination of some parakeratotic debris in the stratum corneum along with a few degenerated inflammatory cells and usually accompanied by fibrin. This can happen either in when the patient has scratched the skin, which has resulted in an outflow of these neutrophils with some parakeratotic debris and fibrin on the stratum corneum again. Next term that we are going to discuss is the spinous layer. So whatever terms are pertinent to the spinous layer are usually the terms which start with the word acantho. So you must have read your acanthocytes in hematology, which actually the literal meaning of acantho is spine or a prickle. And in skin, acantho is usually applied to the changes in the spinous layer of the epidermis. So the first term is acanthosis. Very simple, it just applies to an increase in the thickness of the stratum spinosum. Now this increase in thickness can either be a regular acanthosis, wherein at the bottom of these DT ridges you can practically draw a straight line, and these we call as regular acanthosis. And when it's all over the place and you can't really draw a line as to where the acanthosis is ending is when you call it as irregular acanthosis. The second term is acantholysis. So lysis just means a breakdown, and in acantholysis what's happening is that the intercellular junctions between these different keratinocytes are actually getting disrupted. So you can imagine that this keratinocyte is actually being pulled around by its intercellular junctions in all directions, which results in a polygonal shape of a normal keratinocyte sitting in the stratum spinosum. But when these junctions are lost, the cell kind of acquires a rounded shape, and that is what we call as acantholytic cell. The next term is hypogranulosis. So the granular layer is a layer which is between the stratum corneum and the stratum spinosum, and it usually contains the keratohyalin granules. A reduction in the thickness of granular layer can happen, or an increase in the thickness of granular layer can happen. And obviously the terms for them are very simple. You have hypogranulosis when there is a reduction in the thickness of granular layer, and you have hypergranulosis when there is an increase in the thickness of granular layer. Again, please remember, whenever you're talking about increase or decrease in the thickness of a particular layer of the epidermis, you should know where your biopsy is from, because acral skin has usually an increased thickness of all the layers. So the terms hyperkeratosis, hypergranulosis, acanthosis have to be used sparingly in the acral skin, only when you're sure that it's actually increased. Remember that in a single biopsy, you may see different areas of the similar changes of opposite changes. So here you see these alternating areas of hypergranulosis, over which you have this orthokeratosis, followed by hypogranulosis, above which you will see a parakeratotic corneum, followed by again a hypergranulosis and orthokeratotic area. This is a typical picture of what we call as inflammatory linear verrucous epidermal nevus, where you can see different changes. So in a single biopsy, you have to look at all the areas and describe everything in detail about whatever is happening in the epidermis, dermis, and the subcutis. Next is a relatively simple term, which is a follicular plug. It's nothing, a plug which is dilating a follicular infundibulum. So you see a follicular infundibulum here, and when it gets filled with keratinous hyperkeratotic material, it's something that we call as a follicular plug. The next one is also kind of limited to the stratum spinosum, but may extend to the other layers, which is your spongiosis. Spongiosis is nothing but an increase in the intercellular edema in the epidermis. So in a mild or a moderate form, you will see something like this, where you can actually see some spaces sit in between these keratinocytes. But remember that these keratinocytes are not acantholytic because they're still joined to each other by some remnants of intercellular bridges, and they're not really rounded. But when the spongiosis becomes extensive, you may actually get something that we call as a spongiotic vesicle. Another term that we used in the skin is pseudoepitheliomatous hyperplasia. So in the older time, epithelioma was another term for a squamous cell carcinoma. So a pseudoepitheliomatous hyperplasia is usually used to describe a condition where the skin is so hyperplastic, the epidermis is so hyperplastic that it actually mimics a squamous cell carcinoma, but there is no true invasion when you will look at these areas, and that is what we label as a pseudoepitheliomatous hyperplasia. Coming back to the word acantho. So acanthoma is actually just a benign proliferation. It is a circumscribed proliferation with an increase in the thickness of the spinous layer. It will be a lesion which will be limited to the epidermis, and usually it is because of an increase in the number of cells and rarely because of the increase in the size of cells or both. Here you can see a beautiful clear cell acanthoma where there is a very circumscribed clean lesion which is showing you a significant increase in the thickness of the spinous layer and nothing else much significant happening. There are two terms again which are used to describe a loss of the epidermis thickness. One is a partial loss, which is an erosion, where you will see just the top layers have actually been beheaded. And the second is an ulcer, which is a loss of the entire thickness of the epidermis. And this is usually accompanied by an underlying dense acute inflammation with some karyorectic debris and a lot of fibrin deposition, which tells you that this is just not an artifactual beheading of the epidermis, but actually it is a true ulcer because it is associated with some reaction underneath. Next we have two terms, which is a blister and a vesicle, which are both used under a common term, which is a bulla. So when it is less than 0.5 centimeter, we can call it a blister, and when it is more than 0.5 centimeter, we call it a blister, and when it is less than 0.5 centimeter, we use the term vesicle. These are usually intraepidermal or they can be subepidermal, and these two have very different pathogenesis. The intraepidermal bullae may be secondary to spongiosis, acantholysis, reticular degeneration, and the subepidermal bullae may be because of disruption of the basement membrane components. You may get artifactual separations because of interface alterations and sometimes due to dermal edema. This is a whole chapter for discussion about the pathogenesis of these immunobullous lesions of the skin. But just to touch upon, you should know these two terms. One is a vesicle and one is a blister. When you fill any vesicle or a blister with a lot of neutrophils, or you get something that we call a pustule. Most pustules tend to be subcorneal, but they may also be intraepidermal or subepidermal. And just remember that it is a vesicle or a bulla which is filled with neutrophils. Another term that we like to use in the epidermis is exocytosis. Exocytosis is nothing but presence of inflammatory cells which are traversing into the epidermis. Usually these exocytoses are associated with spongiosis, but whenever you're labeling something as exocytosis, it helps to notice if it is a lymphocytic exocytosis or if it is a neutrophilic exocytosis. Another term about these keratinocytes is something that we call as dyskeratosis. Dyskeratosis happens when a keratinocyte is in the hurry of getting mature, and in the attempt to premature maturation, it does not lose its nucleus. It actually retains its nucleus, but it gets keratinized super fast. So you will see a cell which has retained its nucleus and yet has developed a super pink, nicely keratinized cytoplasm. So these have highly eosinophilic cytoplasm with a retained nucleus, and it is an attempt at rapid maturation of these keratinocytes, which we call as dyskeratotic keratinocytes. Coming to the changes of the basement membrane or the epidermal dermal junction, we have something that we call as hydropic degeneration of the base of the epidermis or vacuolar epidermal interface alteration, which is basically, as you can see here, the basal layer is nice and intact, but here you have a massive destruction of the basal keratinocytes, with some intracytoplasmic vacuoles in these basal keratinocytes, a few dyskeratotic keratinocytes here and there, and usually it will be accompanied by a lymphocytic infiltrate. And this combination, actually the last layer, when it gets vacuolated with an interface change, we call it vacuolar epidermal interface alteration or hydropic degeneration. Usually you will see colloid bodies present when these changes are happening. These are oval to round shaped bodies, and these actually form because of apoptosis of the keratinocytes. Now, a major difference between this and a dyskeratotic keratinocyte is that this is just a cell which decided to get apoptosed, and that is why it will not have any nucleus. On the other hand, dyskeratotic keratinocytes are usually sitting higher up in the epidermis, and they will have a retained nucleus with a supereosinophilic cytoplasm. But an apoptotic keratinocyte will usually be sitting lower down. It may actually sometimes happen higher up in different etiologies. And these are typically found around the basement membrane in interface dermatitis. We also label them as civet bodies, and these have a nice homogeneous eosinophilic appearance. And if you're ever confused, a PAS stain with diastase digestion is very helpful, because these bodies are actually PAS positive and they are resistant to diastase digestion. So a PSD stain will actually highlight these bodies. So these are the main findings that you will see in the epidermis. Remember to actually notice the epidermis from the top, which is your stratum corneum. Look for hyperkeratosis in the form of ortho or parakeratosis. Look for any crust or a scale. Look for any pustule. Within the epidermis, look at the granular layer. Do you think it is hypo or hypergranulosis? Do you think that there is thickening of the stratum spongiosum, which will actually lead to you saying that there is acanthosis? If there's acanthosis, look if it is regular or irregular. Is it actually forming an acanthoma? Is there any acantholysis going on? Are there any interface changes? Is there any vacuolar degeneration? Do you see any apoptotic keratinocytes? Higher up in the epidermis, do you see any dyskeratotic keratinocytes? And slowly, as you go along through the epidermis from top to bottom, you will notice that you will be able to use all these terms in most of the biopsies. Of course, don't forget to look for exocytosis, and when you find exocytosis, do remember to describe if it is neutrophilic or lymphocytic. Coming to the changes which you see in the dermis and the subcutis. So the first term that you notice in the dermis is going to be pigment incontinence, which is nothing but when the melanin pigment in the basal layer gets disrupted and you start seeing it somewhere in the dermis, we label it as pigment incontinence. When this pigment gets eaten up by the macrophages here, they form what we call as melanophages. Now the dermis usually is very rich in blood vessels, and because of damage or vasculitis happening in these blood vessels, we usually use a term that we call as leukocytoplasia or leukocytoclasis. It is nothing but a destruction of the neutrophils which are actually causing vasculitis, and when these neutrophils undergo destruction and karyorrhexis, you will see what we call as leukocytoplasia or leukocytoclasis around the blood vessels of the dermis, and this is typical of leukocytoclastic vasculitis. Another very interesting and fascinating term is homogenization of collagen. So when you see a dermis, usually in most of the skin biopsies, you will see these thick collagen bundles sitting across each other, kind of slightly haphazardly, yet having some kind of arrangement. When you can't see these individual collagen fibers separately and they kind of form a mass of homogenized eosinophilic material, not really amyloid, but just this collagen fibrils sitting in the dermis, we call it as homogenization of collagen. When you see homogenization of collagen, it helps to notice if it is happening in the upper dermis or the papillary dermis, is it happening in the mid dermis, or is it pandermal, because it helps you clinch very different diagnoses. Coming to the inflammatory infiltrates which can happen in the dermis. So again, you can have any kind of acute infiltrates, you can have these chronic infiltrates, you can have neutrophil rich infiltrates, plasma cell rich infiltrates, just a random infiltrate of lymphocytes with a few histiocytes or a histiocyte rich infiltrate, and all of these would point to very different etiologies, and you will be able to clinch the diagnosis when you notice what is the type of infiltrate, acute, chronic, plasma cell rich or whatever, and also what is the location and the pattern of the infiltrate. Is the infiltrate happening just in a perivascular location? Is the infiltrate happening in a perivascular and periadnexal location? Like here you see some eccrine glands which are surrounded by the infiltrate. Is the infiltrate happening in a perifollicular manner or just perieccrine? Is it limited to the upper dermis or is it also extending into the mid and lower dermis? Is the infiltrate perivascular but extending into the interstitium? You call the infiltrate as interstitial if it is actually extending in between the different collagen bundles. You can see here the infiltrate is separating the collagen bundles of the dermis. So if you see that, that would actually be a interstitial infiltrate. And always remember to notice whether it is limited to upper, mid or lower dermis or is it pandermal. Is the infiltrate just perivascular, pericrine, perifollicular or also extending into the interstitium, and what is the type of the infiltrate. Lastly, coming to the subcutaneous fat. So any inflammation happening in the subcutaneous fat is labeled as panniculitis. It usually affects the connective tissue septae which are separating the lobules of these adipocytes. And again, whenever you see panniculitis, there are a few things to notice. Number one, what is the nature of the infiltrate? Is it again acute or chronic? Is it lymphocyte rich? If you see lymphocytes, remember to check, are there any atypical lymphoid cells within that infiltrate? Because a lot of panniculitis can actually be representations of lymphomas happening in the skin. And lastly, also notice if the infiltrate is septal or lobular. So we label it as septal panniculitis if it involves the fibrous septi, and we label it as lobular panniculitis if it involves the lipocyte lobules. So these are all the basic terms that we use in dermatopathology, starting from the epidermis, dermis and subcutis. The actual number of terms are very vast and you will learn a lot of them as you go along into the depths of dermatopathology, but at least these basic terms should be known to you to describe any skin biopsy in a detailed manner so as to enable you to match the description to whatever is the differential suggested by the dermatologist, and it can help you reach the final diagnosis. Thank you.